Awesome. Thank you, Courtney. So my name is Ryan Johnson. I'm one of the R3s, and today I'm going to be talking about sickle cell disease, mostly focusing on inpatient management and complications, since we're more likely to see these patients in the inpatient setting as internists and generalists. I actually got the idea for this talk because I was on an inpatient hem-onc rotation a couple months ago and back in February, and we had two different sickle cell disease patients who typically would go to the platinum team, and we don't often see them in our residency program. I remember taking care of patients like this in my medical school, though, much more frequently. And so I imagine that when we go off to practice in places that aren't UW, that we might see these patients more frequently. So without further ado, going into outline, we'll first talk about learning objectives for today, talk about background and pathophysiology of sickle cell disease, talk about some disparities that we see in sickle cell disease, complications, kind of going through a case-based format for that. And then we'll have some opportunity for questions. I have no disclosures. So first learning objective for this morning, I'm hoping that we can understand the pathophysiology of vaso-occlusive disease and sickle cell disease. Secondly, want to be able to describe the challenges and disparities that exist for patients with sickle cell disease in the United States. And then thirdly, identify the three most common complications that we see from sickle cell disease in the inpatient setting in their initial management. So the pathophysiology, so as we know, sickle cell disease is a multisystem disorder that's caused by a single gene mutation in the hemoglobin protein that can affect nearly every organ. This inherited mutation in hemoglobin to the hemoglobin S form causes abnormal red blood cells that lose their traditional shape and get damaged when deoxygenated due to hemoglobin polymerization. So these damaged cells have abnormalities on the cell surface that cause them to clump and block small blood vessels, which is the pathophysiology for many of the complications that we'll talk about today, is vasoocclusion. This can cause ischemic damage to tissues, resulting in severe pain or even organ failure. So about the prevalence of sickle cell disease, about 100,000 individuals live with sickle cell disease in the United States alone, and it has about a 0.1% prevalence in the world. The causative mutation primarily arose in the African continent because of the protective effect of the carrier state against malaria. So most patients with sickle cell disease have shared African ancestry. But although sickle cell disease is a global disorder affecting people of all races, in the US, as a result of transatlantic slave trade, nearly all patients with SCD are Black. It affects sickle cell trait itself, just the trait alone affects about 12% of Blacks in the United States. So getting into sort of pathophysiology and the cycle of vasoocclusion, it's a vicious self-perpetuating cycle, unfortunately. So starting at the top here, we have vasoocclusion reduces and blocks blood flow to organs and promotes ongoing vascular inflammation and endothelial dysfunction. This can lead to vasoocclusive crises and pain crises that can present as a number of organ complications. And then vasoocclusion itself results in ischemia and can cause damage anywhere in the body, and ischemia itself from blockage of blood flow and oxygenation, but as well as ischemia reperfusion injury that can inflict further damage as blood flow returns through the blood vessel. For these patients, vasoocclusion occurs systemically during their entire lifetime and may actually result in complications, whether or not it actually results into a vasoocclusive crisis. Other complications include hemolysis and hemolytic anemia that can further cause complications and organ damage. So why is it important for us to talk about sickle cell disease as internists? A couple different reasons. Firstly, patients with sickle cell disease have poor outcomes and have been shown to have significant barriers to adequate care, unfortunately. In the United States, as I already mentioned, sickle cell disease affects Black Americans predominantly. And this exemplifies and is amplified by many of the already existing underlying health disparities that exist for Black Americans in the United States. SCD carries a high mortality rate. Life expectancy is actually somewhere in the early 40s. So adults with the most severe forms of sickle cell disease have a lifespan that is 20 to 30 years shorter than that of those without sickle cell disease. And unfortunately, those affect young people. About 1 in 6 deaths that occur in those with sickle cell disease occur in those under the age of 25. And then nearly half of them occur in those over the age of 44. The other thing is that sickle cell disease accounts for a high utilization of resources. So vaso-occlusive crises account for nearly 200,000 ER visits a year, which is about a rate of 2 annual visits per patient. And this is actually 4 times higher than the rate for patients with CHF and 13 times higher than the rate of those of patients with HIV. So why are health outcomes so poor in the patients with sickle cell disease? A lot of different reasons that have been explored in the literature. Firstly, patients with sickle cell disease are often marginalized and dismissed when seeking medical care when their bodies hurt. And there have been studies that have actually looked at patients' ratings of patient-provider communications, and poor patient-provider communication from their perspective has been shown to lead to more hospitalizations, more readmissions for SCD complications. Thirdly, there is significant delays both on the delivery of care from the providers as well as presenting to care from the patient side. And so studies have shown that typically as physicians, we tend to underutilize proven and known therapies for sickle cell disease, including hydroxyurea, prophylactic antibiotics for children, iron chelation, bone marrow transplantation, and pain management are significantly underutilized. We have these therapies that we know that work, but we just aren't using them as frequently for these patients. Also, oftentimes patients with sickle cell disease are described as drug seekers and accused of feigning their pain, which results in more inadequate treatment and more suffering. And then from the patient side, patients often feel this stigma and this trauma from their prior care. There's a study that was published in the Annals of Emergency Medicine with a group of patients with SCD, and they found that prior negative experiences with healthcare system and a perceived stigma of their disease led to patients delaying presenting to care for vaso-occlusive crises, even though they were in significant pain. And unfortunately, it breaks my heart, patients will try to get dressed up and look nice before going to the ED so they can get adequate care from patients or from their doctors. So because of the challenges in getting adequate care, stress with coming to the ED, perceived racial stigma, many patients actually choose to avoid care altogether, which further increases the risk of complications that can threaten their life. Another thing that we see is that about half the patients that are admitted for crises from SCD are discharged prematurely while they're still in significant pain, and there's about 50% risk of readmission within 30 days. So as we know, frequent and prolonged hospitalizations really can disrupt your daily life and have a high risk of mortality. And the last thing I'll say about just reasons why we may see poor health outcomes and disparities in SCD patients is just inadequate research funding. Even though SCD was first described more than 100 years ago, the development of disease-modifying therapies has actually stagnated because of lack of research funding. And this is often compared to other genetic but life-altering diseases such as CF. So I just want you also to think about what the role of race and the role of racism might play in these funding allocations and resource allocations. So not to be a downer, but what do we do about this? How do we fix this? I love to see any folks that might have ideas to throw them in the chat about how do we combat as providers these disparities that we see in these patients. Any thoughts? Or feel free to unmute as well. Yeah, so being conscious is the first step I see. Making informative academic half-day talks.
Recognize. I was gonna say, like, maybe, yeah. I don't know, like, we don't, like, why don't, I know it's a service thing, but like we as residents, like, don't care for these patients. So it like might be worth like having a conversation about if that's something that needs to continue, because like, you know, we can't, I feel like we're not going to like learn how to provide better care unless we just learn how to care for these patients. So maybe that's something we should start talking about at like a program level too.
I totally agree with you, Tess. I think it's a definitely a gap, at least in our training, to not take care of these patients. Although I think with the pandemic, we're seeing a little bit more of them on the hemongrain side than we had previously. Let's see, more exposure during training, I see. Dedicated funding sources for research about disparities. That's a great idea, Anisha. And I'll throw up some, there actually was a good New England Journal of Medicine article about this specific topic. And I just picked out some of my favorite kind of interventions or solutions that we have. And what Anisha said is actually one of them. So we should have federal funding for comprehensive SUD centers, universal screening for social determinants of health for patients with SUD, kind of utilizing both community and governmental resources. These patients require a lot of psychosocial support, social workers, navigators, psychologists. And there's also been data that shows that sickle cell disease specific protocols, whether it's for pain management or other types of care, actually help reduce time to opiate administration. And then one thing that comes up a lot is the word sickler, and using that word to describe patients with sickle cell disease, which is very dehumanizing and has some racial undertones too. And so we should avoid using that word. And if we hear it from other colleagues, call them out on it. I think Priyanka said too in the chat, it's important to be aware of negative biases that we hold and model how we talk to patients with our team and colleagues. That's a great point. All right. Any other thoughts about that? Last minute comments before I move on? All right. So the next part of this talk, I wanted to talk about the kind of 3 really common complications that we'll see from SCD in the hospital, and kind of have this as a case-based format. I didn't make any polls, but feel free to drop answers or thoughts in the chat about management and ask any questions. So the first case, we have a 29-year-old patient who presents to the ED with severe pain in the legs. The history reveals that she has sickle cell disease, SS genotype, and has been hospitalized 3 times in the last year for sickle cell crisis. How would you assess this patient and their pain? Well, firstly, what complication is this? Can someone just name it? It's kind of an easy question. We were just talking about it. What does this patient have?
Vasoocclusive disease.
Yes, vasoocclusive pain crisis. Yes, absolutely. I don't know who that was, but thank you. And then any thoughts about how we can assess patients' pain and how that may be different from other patients coming with acute pain that we might see in the emergency room or on the inpatient side? Ask the patient, yes. Any specifics about what questions that'd be good to ask the patient about their pain?
I think it would be important to assess what kind of pain medications they've been on at home, because oftentimes these patients, you know, they do have opiates at home in you know, different regimens, and they may be trying their usual regimens, because I think a lot of patients try to manage their pain crises at home if they can and can get through it. But if they can't, then you need to kind of adjust your inpatient regimen based on their home regimen.
Yeah, that's a great point, Linda. So that's definitely true. A lot of patients, as we talked about already, will oftentimes try to manage at home with their existing prescriptions and in order to avoid coming to the ED. And so asking about their typical regimen and what they're starting with, and knowing that we have to escalate if they're having an acute pain crisis is really important. Someone also mentioned that they often have a pain plan in place already for pain crises, which will help guide the appropriate doses, which is hugely important. Oftentimes in, well, I don't know where it shows up now in the new D1, but previously there used to be care plans that would come up for patients that have a pain plan with very clear instructions as to how to follow. That's developed between the patient and their hematologist, which is really useful. So some questions that are useful to ask patients. So obviously we have our typical OPQRST, right? How intense is the pain? Where is it located? How long has it been going on for? What things aggravate or alleviate the pain? And then oftentimes these patients have experience with pain crises in the past. And so getting a sense of, is this your typical pain crisis, or is this different in any way? And if so, how is it different? Because it's important to keep an eye out for anything that's new or different that could indicate an underlying more severe complication. And then, as you already mentioned, how do you typically manage a pain crisis? Do you have a pain management plan? What medications and doses typically work for you when you're admitted for this? And trusting the patient when they say what their typical doses of medications are. And then we talked already about what medication to take at home, when they took the last dose, what route they take them by, et cetera. And then general management of these patients that come in with pain crises. It's really important, as I mentioned before, to assess for complications while treating their pain. So being concerned for another complication like acute chest syndrome or stroke or anything else, that doesn't take priority over giving them pain medications. That should be happening simultaneously as you work them up. It's really important to treat their pain aggressively. So actually the goal in the literature is that we should be giving IV pain medications within 60 minutes of them coming to the ED, or within 30 minutes of them being triaged and seen by a provider. And then it's important not to just give them medication and then walk away and ignore them. You should be checking on the patient every 15 to 30 minutes or so and redose them if their pain is not improved. So if they're still having severe rated pain per their own report, they need a higher dose. For patients that don't have an individualized pain plan with their hematologist, there are weight-based dosing protocols that you can find online. Typically, they start with hydromorphone, like 0.02 mg per kg, or morphine, 0.1 mg per kg as a starting dose, keeping in mind that we're going to be escalating, as we talked about already. Another thing that's important is that if patients are on long-acting pain medications at home, these should be continued. This is to keep their basal pain control adequate, and then we're dosing on top of that. And then one little pearl that I didn't realize and discovered when doing the research for this talk was that meperidine should not be used in these patients for pain crises unless it's the only thing that has worked for them in the past, because it can increase their seizure risk. All right, questions about managing vaso-occlusive pain crises.
Yeah, Ryan, I'm wondering if I've kind of wondered in the past, I've seen some of these pain plans that have been documented, and some of them haven't been touched in really long periods of time. And I've kind of wondered in some circumstances whether, as great as they can be, they may handcuff us in certain situations, because I think it's really easy to be like, oh, we'll just execute the pain plan. And I know that there's, over time, a lot of that is about expectation setting and a long-term relationship with the hematologist. But I do wonder if sometimes it also gives us a license to undertreat things. Totally. And not make adjustments when maybe we need to, or there's something new that's going on. So I don't know if that's come up or you've thought about that or how to handle that.
Yeah, that's actually a really great point, Ryan. In an ideal world, this pain plan is developed and updated, and you're right, comes from a relationship with a hematologist in the outpatient setting. And so if that's not the case, if it's something old, really just trust the patient and what they're telling you, and have a low threshold to get the pain service involved for any escalations or deviations. If you wait too long to do that, then you're having this patient sit in pain and suffer. And so if you're concerned, or the patient's concerned that the pain's not being adequately treated with the current pain plan, I would have a low threshold to get them involved to escalate. I'm looking at the chat here. Is there a role for IV hydration? Does that help? Yes, there is a role for IV hydration, not necessarily in vaso-occlusive pain crises, but we'll talk a little bit more about other complications that hydration is actually really important for. actually, I've seen patients in their pain plan to have a certain maintenance IV fluid rate that's part of their pain control. So it can help, not necessarily something that's standard of care though, for pain crises. And then Melanie asked what percentage of patients are on long-acting opiates as outpatient. I'm actually not sure about that. I can get back to you. I'm not sure how common that is. I'm not sure. And then have non-opiates been explored like ketamine? There is a role for non-opiate medications, particularly in children, is what I've seen in my research at least. I haven't seen ketamine actually used for that. It's actually interesting because I know it's becoming more popular lately. All right, other questions. One thing I actually see sometimes that comes up is opiate-induced Paritis. That is a very common complication of IV pain medications. Oftentimes these patients will have in their pain plan incorporating how to use antihistamines to treat that Paritis, whether it's PO or IV, and how frequently. All right. Move on to this next question here. This is actually a mix-up question. I'll go through it quickly. I won't read every word, but we have a 24-year-old man coming to the hospital for fever, chest pain, dyspnea, and cough. He has sickle cell disease, the SS mutation. He takes folate and hydroxyurea. On exam, he is febrile, 38.9. Blood pressure is 100/70. His tachycardic to 110. Breathing at 22 per minute. Setting at 90% on 40% oxygen. He looks ill. He has a murmur and crackles. His labs show a hemoglobin of 7.8, white count of 22. Chest x-ray shows bilateral lower lobe infiltrates. And he receives hydration, so IV normal saline. He receives VTE prophylaxis, ceftriaxone, and levaquin. And he starts with spirometry. 6 hours later, he has worsening hypoxia and respiratory distress requiring intubation and ventilation. A repeat chest x-ray shows worsening infiltrates. So I'll go to the next slide here. I didn't make this a poll, but just feel free to drop a letter in the chat. Which of the following is the most appropriate management for this patient? CTPA, exchange transfusion, IV amphotericin, full dose heparin, or Doppler? Seeing some B's in the chat, which is awesome. Great. So yes, B is the correct answer, exchange transfusion. And I'm going to kind of talk through some of the different complications. So this patient has acute chest syndrome. It is one of the most common complications of sickle cell disease, and actually the most common cause of death in patients with sickle cell disease. About half of patients with sickle cell disease will have an episode of ACS in their life. And 78% of those ACS episodes come with a vaso-occlusive pain crisis. And so usually we should be on heightened alert for patients that are coming in with a pain crisis and looking out for signs and symptoms of acute chest syndrome. And usually it sometimes will happen around 48, 72 hours into their hospital admission for pain. The key thing here is that ACS is actually a clinical diagnosis. There's no lab test that you can do to diagnose it. So the clinical criteria are any respiratory finding like dyspnea, cough, wheezing, pleuritic chest pain, fever, being hypoxic, having crackles, respiratory distress, all those respiratory symptoms. That plus any pulmonary infiltrate on chest x-ray is a diagnosis of acute chest syndrome. The pathophysiology, I have a little diagram here about how vaso-occlusion in the pulmonary vasculature is really the basis for underlying ACS. This can be either triggered by infection or asthma, or it could actually be the result of. So it's kind of a cycle, as many things in STD are. When patients are in pain, if they have bone infarcts to their ribs, they might be splinting and hypoventilating, which puts them at risk for infection ACS. And also there's hypothesized that bone marrow necrosis from vasoocclusion in the bones, long bones, leads to marrow fat embolization in the lungs, and then parenchymal ischemia and infarction. These patients can rapidly decline and have a high mortality. So it's very important to upfront get a chest x-ray for patients coming in with a pain crisis to make sure they don't have any infiltrates, and 2, to assess their symptoms very closely. So what about management of ACS? And I'm saying ACS meaning acute chest syndrome, not acute coronary syndrome. It's kind of confusing. But the mainstay of therapy, firstly, includes incentive spirometry. There's evidence from a small clinical trial that incentive spirometry actually prevents ACS and supports the kind of role of that bone infarct, hypoventilation, pain, atelectasis, that is parts of the pathophysiology of ACS. And then 2, patients with ACS should get empiric antibiotic coverage kind of across the board. It's actually clinically impossible to differentiate between pneumonia and ACS. So they're actually treated as the same clinical entity in patients with sickle cell disease. And therefore we should be covering these patients with empiric antibiotics for CAP coverage, usually cephalosporin plus a macrolide or a fluoroquinolone, respiratory fluoroquinolone. And then also, as we kind of talked about with this case, transfusion is indicated in moderate to severe cases. And the severity of the ACS will determine the need for the transfusion or the type of transfusion, if it's simple or exchange transfusion. I'll talk more about exchange transfusion a little bit later. If it's a really mild episode, it doesn't require any transfusions. Moderate episodes, you can kind of go away with a simple or exchange. And then severe episodes, as this patient has worsening pulmonary infiltrates, refractory hypoxemia and respiratory distress requiring intubation, mechanical ventilation, those are indications for exchange transfusion. And we also want to make sure we're watching out for complications of ACS, including ARDS, multi-organ failure syndrome, which is seen in SED, which is what it sounds like, multi-organ failure. And interestingly, steroids and non-invasive ventilation have not been shown to be beneficial. All right, I see some questions in the chat. So what's SpO2 target for ACS? 92% or higher. That's our SpO2 goal. And so if patients are below that, we should have them on oxygen. Does this change if the patient is on prophylactic antibiotics for asplenia? No, that would not change your antibiotics. You still would cover your typical strep pneumo and atypical organisms for ACS in this case. So usually ceftriaxone is azithromycin. You also can use clindamycin if there's penicillin allergy, or a fluoroquinolone. So yes, logistics question. Yes, so Mr. Vanka said about getting a transfusion, exchange transfusion as an order. I'll talk a little bit more about that in a couple slides from now. And yes, I mean, as in we should not be delaying intubation for these patients if they have refractory hypoxemia or respiratory distress that's worsening. They should be intubated early. Does that answer everyone's questions? All right. So just a quick slide. I won't go into detail for this for time's purposes, but other complications we can see from vasoocclusion include stroke, TIA, renal infarcts, the classic dactylitis, bone infarctions, which can be very painful, and avascular necrosis. We can see heart attacks, we can see priapism, and we can see thromboembolic events. So what about transfusions? This can be a little bit confusing. I felt, at least, when I took care of these patients. And when do you transfuse? These patients are typically chronically anemic. And when should we transfuse them? There's a couple of different indications I'll go over in the next slide. But oftentimes over the lifetime, these patients will have a lot of red blood cell transfusions in their lives. And they come with your typical complications like transfusion reactions, alloimmunization, tapo and trolley, Infections are actually as high rates, higher than average rates of hepatitis B and C worldwide, not necessarily in the United States, because of transfusion dependence of these patients. And iron overload we can see as well. One specific thing to sickle cell disease that we can see is hyperviscosity. And so hemoglobin SS blood has a 10 times higher viscosity than non-sickle cell blood does at the same hemoglobin level. And so if you transfuse patients who have a sort of low to normal red hemoglobin level, this can increase the already hyperviscous state and create even slower blood flow through vessels. That can actually result in more sickling and trigger or worsen a vaso-occlusive crisis. So kind of similar to our patients we see on the hemonc service with very high white counts. These are very sticky. We want to be careful with transfusing these patients. And our hemoglobin goal actually is about 10. And so for patients who have a indication for transfusion and are lower than that, the safe transfusion threshold is up to 10 and not higher, because once you get to 11 or so, you're really increasing the risk of having hyperviscosity. And then what are indications to not transfuse, or when do you not transfuse? If it's a simple vaso-occlusive pain crisis and does not have any symptoms, symptomatic anemia, you would not transfuse. Also, there's kind of actually wishy-washy data about priapism and transfusion for that. And expert consensus right now is to not transfuse for priapism routinely. And also we would not transfuse for acute renal failure unless there is another indication on top of that, or there's concern for multi-organ failure syndrome. That would be another reason to transfuse. So exchange transfusion, getting into Anka's question earlier, how do we actually do that? This requires a pheresis line or a dialysis line for the patient. The way it works is actually it involves removing the patient's blood, giving them blood back, and they're actually lowering the concentration of hemoglobin S and diluting it out essentially. And it increases your volume of donor blood exposure, so your risk of alloimmunization is much higher. And this definitely would require a hematology consult. Logistically, the hard things to do is getting the patient access. But then once you have them access, usually it's quite simple. The machine itself removes all of the red blood cells and puts back in packed red blood cells essentially, and gives back everything else in the blood. So here on the left side of the slide, I just have some indications for both simple and exchange transfusions, and I put stars next to the absolute indications for exchange over simple transfusion. You have that risk, as I mentioned before, of hyperviscosity, and so exchange transfusion actually eliminates that, which is nice. So severe acute chest syndrome, you would definitely need to basically only use exchange transfusion. And then stroke is another indication for exchange transfusion as well. Let's see, I have a question about UW. I have not run into an issue with us having an available machine. I'm pretty sure we can do this relatively easily in my experience. Some smaller hospitals will transfer patients to UW specifically for exchange transfusion because they don't have the capacity to do it there, but we can do it. And is there a higher rate of risk of heart failure in SCD patients? Absolutely, yes. But for two reasons. One, what you're saying, Hasib, for the transfusion and volume, iron overload is another complication that can lead to heart failure, as well as like microthrombi and micro ischemia causing cardiomyopathy over time. Certainly do see that. All right. So any other questions about exchange transfusion, simple transfusion, any of that stuff, when to transfuse? And of course, your hematology colleagues are probably going to be helping you with these decisions, but it's important for us to know sort of the general principles. All right, I'm going to go on to the last complication. So here we have a 19-year-old patient, history of sickle cell disease, coming in with fever and malaise. He has a history of acute ischemic stroke at age 17 and has been getting monthly simple transfusions every month since the stroke. She has a Tylenol CVC for this. She is febrile at 39.1, heart rate is 110, blood pressure is 104/72. So what are we worried about for this patient coming in? I'm seeing some questions from before about who does, I think access, is that what we're talking about? I don't think HEMOC themselves puts these lines in. They would have to be either in the unit at bedside or during the day by IR. Yep, that's right, Joan. How good is the VA at SED management? Do they have exchange machines? That is a great question. I don't know the answer to that. I believe that places that have readily accessible plasmapheresis capabilities can also do red cell exchange, but I'm not 100% sure about the VA and what they can do. Okay, so for this case, what are we concerned about for this patient coming in with fever with SED? Totally, Annie, yes. Obviously, fever, risk of infection, yes. And yes, they have an indwelling tunneled CVC, and so line infection or CLABSI is definitely of the highest concern, for sure. So, infection is a major cause of morbidity and mortality in patients with sickle cell disease. Thinking about particularly invasive bacterial infections and risk of severe infection is higher than the general public. This is because of splenic and immune dysfunction. And so patients with sickle cell disease have functional hyposplenism from splenic infarction at a very young age, oftentimes as early as 4 months, but typically between ages 2 and 4, you're functionally asplenic after that. And so infants and young children are at the greatest risk of certain infections, particularly like someone said in the chat, Anisha said, encapsulated organisms. Other mechanisms for increased infection risk include reduced tissue perfusion, having an indwelling catheter for chronic transfusions, and then we talked more about splinting before and hypoventilation from rib bone infarcts, and that atelectasis increasing risk for pulmonary infections as well. Bacteremia and sepsis are common in sickle cell disease. In some series, bacteremia accounted for up to 32% of febrile illnesses. And then also these patients are at risk for other infections besides bacteremia, such as meningitis and pneumonias, and actually even vaso-occlusive disease of the bone and necrosis of the bone puts you at higher risk for osteomyelitis in those areas. It can be really hard to tell the difference. Viral infections as well can also be more virulent in patients with sickle cell disease. Thinking about things like parvovirus, flu, H1N1, Zika, COVID, possibly due to increased sickling of the red blood cells and an enhanced inflammatory response as a response to the virus. One thing that's kind of like a board's question is the parvovirus B19, which infects erythroid progenitor cells, can cause a transient aplastic crisis. And so basically your red cell precursor cells are infected and they don't produce anymore and they transiently cease to exist, and then you don't have any production of new red blood cells and can have severe anemia from that. Also, parvovirus has been associated with development of acute chest syndrome, bone marrow necrosis, pain crises, and stroke as well. Yes, thank you, Annie, for listing the encapsulated organisms. Most commonly, we'll see E. coli, strep pneumo, Neisseria, H. flu, and Klebsiella are the classic ones, but there's more as well. So empirically, patients with fever and sickle cell disease will get kind of your standard ceftriaxone, third generation cephalosporin. Some places use cefotaxime instead of ceftriaxone. And then if you're worried about a pulmonary source, definitely add atypical coverage. This is a kind of above and beyond what we typically do for sepsis and infections. If we're worried about MRSA, obviously give VANC, but that's kind of your empiric therapy is going to be a 3rd generation cephalosporin. Questions about infection? I think we're nearing the end of our time shortly here, so. All right. So just a couple of pearls and takeaways in general from this talk. So 1, patients with sickle cell disease have a high morbidity and mortality. We have an obligation as physicians to understand and distress racial disparities in patients with sickle cell disease. We should treat vaso-occlusive crises with IV opiates within 60 minutes of presentation. We shouldn't use piperidine due to seizure risk, unless we have to. Pneumonia in a patient with sickle cell disease is ACS, essentially. They're indistinguishable. And so we should be using antibiotics empirically, regardless if they have an underlying pneumonia or not for ACS patients. And I spelled cephalosporin wrong, plus macrolide or respiratory fluoroquinolone. Should be careful about precipitating hyperviscosity if our hemoglobin is raised above 10 with simple transfusions. So our transfusion goal is actually 10, no higher. Indications for exchange transfusion include stroke, severe ACS, and if you need to transfuse someone for another indication for simple transfusion, the hemoglobin is greater than 10. And so you have to use exchange to have that risk of hyperviscosity eliminated. Patients with SCD are at risk for infections, particularly with encapsulated organisms, excuse me. And empiric antibiotics for fever are ceftriaxone or clindamycin if there's a cephalosporin allergy. And we should add atypical coverage for lung infection or for ACS. And those are my takeaways. I wanted to plug that World Sickle Cell Day is coming up on June 19th. So on Juneteenth. And that's it. Open to any questions that folks have.
Awesome. Thank you so much, Ryan. I think there's, you should hopefully be able to see a lot of thanks and praise for covering this really important topic.